It's late in the day, so this is going to be a very data-light talk, and I think Frank will add a bit of science later about what we should be trying to measure. So, an update on transcatheter mitral valve techniques. I'm not going to talk about MitraClip. I think you will all have heard quite a lot about that, so I'm going to talk about other more novel techniques. I think you wouldn't be in this room if you didn't understand that the mitral valve was a complex structure and much more complex than the aortic valve. And it has a wide range of pathologies from simple to complex degenerative disease, MAC, which we're seeing much more common, functional MR, and the disease which everybody seems to forget about, which is by far the most common mitral valve disease worldwide, rheumatic mitral valve disease. So rather than just calcific degenerative aortic stenosis, you have a wide range of pathologies. So let's talk about dedicated devices for transcatheter mitral valve replacement. And these are the devices that have some clinical experience. This is the Cardiac Q, which has been bought by Edwards. This has a very low ventricular profile, but a high atrial profile. This is the Neovasc Tiara with these fixation devices which sit under the annulus. This is the old 12 device that's now the Medtronic Intrepid, a dual stent where you have decoupling of the outer stent from the inner stent and these little hooks on the outside. I'll talk more about the Tendyne device, which we have some experience with. Again, decoupled inner circular stent, outer D-shaped stent, a tether, and an apical pad. This is a very interesting device, the Caisson device. This is designed for transvenous transeptal implantation, and it's a two-stage device. So there's an implantation of an outer stent, and then the valve gets implanted within the stent. And that's very similar to this, which is the M-valve docking system. Again, a docking system that's implanted, and up to date, this has only been used in a small number of patients, but these patients have had Lotus transcatheter aortic valves implanted within the M-valve docking stent. So what does this all look like in the real world? So we've had some experience with the Tendyne device. These are transapical procedures over a soft wire. Use a sort of flossing technique with a Swan-Ganz catheter to make sure you're not tangled up in the mitral apparatus. Here you see the sheath, which, and all of these procedures I'm going to show you today are very much echo-controlled. I mean, having an echo person who can show you what you're doing is absolutely key. And you see here you have the introducer removed, and here's the sheath central in the valve. For those of you who like fluoroscopy, I use this for the cardiologists because they get upset if you don't see some fluoro pictures. And you deploy the valve to about 80%. You can still see here, it's deployed in the atrium. It's still rather mobile. And then you are able to clock or rotate the valve. So it has a D, you can see here it's not fully deployed, there's still a fold, but it has a D-shaped part to the outer stent, which you locate up towards the aortomitral continuity. Once you get it in the right orientation, you pull it back down, fully deploy it, and here you see a nice valve. I think we'll come back and talk about this, but I think it's important to just notice that this is starting to impinge quite significantly on the left ventricular outflow tract, and that's going to be an issue with all of these devices. Here's a fluoro picture at the end. See the device deployed, and this is a And this is a titanium pin that pins through the tether and through the apical pad. And one of the nice things when we started doing this was the apical pad was a very effective apical closure device, and really you almost didn't need to tie down your purse string sutures at the end once you'd put the pad in place. This was some data from the global feasibility study presented at TCT last year. I don't want to go through them too much, but you see the age range is a bit younger than the typical TAVI age range. And see, half the patients almost have had previous coronary surgery, more than half in atrial fibrillation, half the patients with ICDs or biventricular pacing devices. So just a flavour of the kind of patients who are being treated. I think this is important. I think the Tendyne results are probably better than the other series. Now, I'm not sure that's due to the device. It's the fact that they really have avoided treating patients with low ejection fractions. I think if you're doing these big transapical sheath procedures in patients with low ejection fractions, you're going to have troubles, and some of the other devices have had that experience. 30-day outcomes, not bad. One death. No device migration, one leaflet thrombosis. I'll come back to that. It's something we're seeing in both mitral and aortic transcatheter valves, and actually now perhaps being increasingly recognized even in surgical bioprostheses. I think it's an important slide when you look at transcatheter mitral valve implantation. It gets rid of mitral regurgitation. Compare this to the sort of slides you see with MitraClip, where half the patients still have 1, 2+ MR. These devices do get rid of mitral regurgitation. So what did we learn from the first few patients we did under a compassionate use protocol? The first was you have to face some problems with these devices. As a second patient had a paravalvular leak. Fortunately, this has not been a problem, and it's actually looks like it's got less over the duration of time, and this patient's more than 2 years out and very well. This was the biggest problem that we have. This is deliberately a still picture. Here you have a narrowed left ventricular outflow tract, and this is the anterior mitral valve leaflet. So this was the gradient that we had at the end of the procedure, and the patient was not very well. And I think people talk about putting STLs of these devices into CT scans and measuring the LV outflow tract. It's not as simple as that. The anterior leaflet and the ventricular septum are really key in this. And so this is what we had in this patient. She'd had a previous repair. She had a very long anterior leaflet with caudal ruptures. The anterior leaflet was unsupported, so it was able to just prolapse and cause outflow tract obstruction. And the data that underpins that is we stented the anterior leaflet to the tendine, got rid of the gradient down to about 20 milliliters of mercury, and she's still well 2 years out. So it's not just a physical fact, but LVOT obstruction with most of these devices is going to be a key problem. The other problem is a patient who was about a year after the procedure, developed an atrial tachycardia. The EP people stopped his anticoagulation to do an ablation, and you see here the formation of clot, not on the leaflets, but on the stent. And my own feeling about these devices, they occupy a lot of real estate in the ventricle and left atrium, and I think we probably need to, even if they're not in atrial fibrillation, anticoagulate them for much longer than we think. Again, with restarting the anticoagulants, the clot went away. So what did we kind of learn from these procedures? Well, four of the 5 are still alive, 3 out beyond 2 years, 1 beyond 18 months. No late migration of the device, no dysfunction of the valve leaflets, no late mitral regurgitation, and no new late paravalvular leak. One of the concerns about this system was what happens with the ventricle remodels and you lose tension on the tether. Will the device loosen? Will it migrate? Will you get PVL? Well, that doesn't seem to happen. Either the tension doesn't decrease, or if it does decrease, the valve is healed in and you don't get PVL. So there's a lot of technical challenges for transcatheter mitral valve implantation, still at a very early stage of development. Wide range of sizes to deal with. How do we fix it? How do you get sealing? How do you get it there? Because at the moment, most of these devices are being implanted transapically with sheath sizes that are in the 32, 34 range. So they're not small sheaths. So what about this pathology? Recurrent mitral regurgitation after prior surgery or repair. You can get very nice results by transapically or transeptally implanting a Sapien valve into these devices. But this is not the most straightforward procedure. The Sapien's a great device, but it's a one-shot device, and if you get it in the wrong place, it's not a very happy scenario. And this is the worldwide registry looking at these kind of numbers that you'll see on the slide. And this is procedural success. So this is 30 days, the patient's alive, doesn't have severe MR, or doesn't have significant left ventricular outflow tract obstruction. Now, these procedural success numbers are not what you see in other transcatheter procedures. So still over 10% of the valve in valves have a problem, and almost 30% of the valve in rings. I think we're probably a bit better than that now. This is slightly old data, but I think it's a shame that devices like this have gone off the market because of the company basically running out of money. And these were recapturable. This was a direct flow device, which was a beautiful recapturable and repositional device for doing mitral valve in rings. And you can see in the bottom two slides how you initially have the device a little bit too ventricular, and then you're able to reposition it so the larger ventricular ring sat up against the annuloplasty ring. So it's rather a shame that that device is no longer with us. So getting back to degenerative disease and the type of things that we as surgeons do. Well, what we do, and I think you've heard some of this already, basically we use neocords to repair these valves, often with an annuloplasty band or ring. So can we do this by a catheter-based approach? Well, the answer is yes. I think many of you probably seen this system. It's been around for a few years now. This is the Neocord system. You have this trench here in which you try to capture the leaflet. It's got some sensors, and when you get leaflet tissue in, I'll show you these lights light up. Sorry, apologies. This is slides from Gino Gerosa in Padua. It's a little bit of a rigid, bulky piece of equipment, but it's not that difficult to use. And you'll see here, they're grasping the leaflet under echo control. These lights light up, and you have a little device here that pulls the cord through the leaflet. So this is one of the patients that we've treated with this device. This all looks a pretty simple repair to do, but maybe not the simplest patient to do. I think even Joe, you might struggle with your mini mitral getting through that right chest, and certainly the patient's not really going to tolerate a median stenotomy. So here is, I think you've got a nice image. Again, all echo controlled. You'll see the device here, the little footprint. Here's the area of prolapse. You capture it, and that's the result that you get after implanting 3 cords. One of the slight issues with this device is that it only will implant 1 cord at a time. So you have to put the device in, take it out, reinsert the sort of kind of 14 French device. So it's a little sort of ergonomically uncomfortable, but it does work. So let's go press these buttons one at a time. I think I've caused it to die. Or it has died, one of the two. Am I out of time, am I? It says here, do I want to turn on sticky keys? I don't know what that means. Yeah, sure. Okay, so this is a device that we've been involved with recently. I think done about 8 of these procedures now. A little bit more sophisticated device called the Harpoon. Very interesting technology. The Gore-Tex is wrapped in a specific way on the needle, so that when you push it through the needle, the Gore-Tex comes off and ties itself in a preformed knot. It comes with a valved introducer that's a 9 French, so really quite low profile sheath. So you can put about 4 sets of cords in through this one valved introducer before having to take it out. So again, sort of slightly ergonomically easier. The point of this slide is not the fact that my glasses weren't working that day and I had to take them on, but you can see it's really quite a delicate procedure. Really is quite delicate. The most important people are here, Andre and Alison, who are doing the echo. I'm looking at the echo screen. It's really just, they go right, left, medial, lateral, and I just follow this very much echo controlled. This is one of the first patients we did. Again, fairly easy to repair surgically. Here's the device. It's got a little T-shaped cap that allows you to follow it. Unlike Neocord, which tends to come recommended to come more posteriorly. This is an anterior ventricular puncture, about lateral to the LAD and about 2 to 3 centimeters up from the apex of the heart. You'll see here the device. This is all done in this sort of X-plane view. So you've got sort of bicommissural view and long axis view. And here you can see we've got the device to the leaflet, and we've fired it into the left atrium. And here we've implanted a number of cords, and you'll see the loose knots flying around on the atrial surface of the leaflet. And again, it's very simple. You pull it down. I think one of the fascinating things about this for us surgeons, we operate on still mitral valves and try to visualize what they're going to be like. Here you have the mitral valve working, and you pull the cords down until you think you've got a nice repair. And you can see here, obviously you can see the cord affecting this leaflet. I think you see it's a pretty good result. This is my favorite slide. This is another patient. You can see here, similarly, a nice surface of coaptation. Crikey me. Sorry, guys. So this is the most important thing. This is 6 months after the operation. I think you would be difficult to be convinced that was not a normal mitral valve. So I think it's very exciting using this technology to produce these kind of outcomes. Well, what about a ring? We keep saying, well, we can't get good results with Cordy alone without a ring. Well, this device, also acquired by Edwards, is able to produce a posterior band. And this millipede device has not been put in percutaneously, that was been put in surgically. This is the potential to do a complete annuloplasty ring. And there have been a very small number of patients done now combining the MitraClip with Cardioband. So we're starting to get to a combination of catheter-based techniques that replicate surgical procedures. So to summarize, there's a very diverse range of technologies have or are being developed. The mitral space is much more complex, more dynamic environment, and it's likely that we will need a number of different devices to deal with these different sizes, different pathologies. The replacement technologies are still in the early stages of development, and I think quite a lot of iteration of those devices will be required before they really come into mainstream practice. And I think, as I've shown you, I hope repair technologies are coming close to being able to reproduce conventional surgical repair strategies. This is an old slide of mine. I think this is TAVI. Anybody can drive one of these. It's quite simple. You can teach anybody to do it. This is transcatheter mitral valve intervention. Much more complicated, much more difficult. It's going to take a while to sort that out. Thank you.